Here's the story of 2020. It was a year for us to live in sync.
So many things that need our understanding. It's time for us to think. It's the story of fellow humans who were busy with lives of their own, but they thought of bringing us together, and we can watch from home. We can all make this world much better. It's about what we're willing to confront. So sit back and enjoy the conversation of these rainbow warriors called the Queer Bunch. The Queer Bunch. The Queer Bunch. It's a great day to watch the Queer Bunch.
Welcome to the Queer Bunch. Hello, my lovely, lovely host. We are missing a few of us, but that's the nature of being artists and being busy and having lives. So, Morgan, Brooklyn, Kenny, you were missing on the last one. Brooklyn was missing on the last one. How are you guys doing? What's happening?
So good. Life is great. I've just moved into a new home.
Oh, cool. Where?
My office background is a little bit different. I still need to get a lot of furniture into the house. I'm now living in Port Colborne near Niagara Falls.
Oh, Coburg. I love that area. Yeah, it's very, very pretty. Cool. Cool. Well, congratulations, Del.
Thank you.
Cool. What's happening musically for you?
I just finished a month-long tour of the States with a punk band, which was very fun and exciting. We opened for Guar, which was such a treat.
Nice.
And now I'm just focused on moving into this new house, getting some work done, and I'm just really excited to be back hanging with y'all.
Lovely. Cool. Kenny, you're always up to a lot.
6 degrees of guar. I can now say that I am 2 degrees of guar.
Yeah, cool.
It's busy. It's a busy time. So my day work, which is executive director for Dance Nova Scotia, of course, it is competition season. So there's a lot of competitions happening. So which it's very interesting because I go to the competitions not necessarily because I'm not competing, but to be present, to kind of see what's going on and that. But there's a lot of them happening, so that's happening. We have our own event coming up this Saturday on April 20th. It is the kickoff of Dance Week. So International Dance Week is the 20th to the 29th. The 29th is International Dance Day. So yeah, lots happening, lots of dance, and then of course my LGBTQ work with the Q network is busy as usual. Lots happening. Just I'm doing lots of Canadian stuff currently.
Cool.
I'm doing some interesting.
You're always pumping out content, and everyone, if you watch this show but you're not you haven't viewed Kenny's stuff, look up the Q review still.
The handle on social is the Q Reviews because I didn't know what I was doing with it back in the day, so I chose that handle. People know it.
yeah. So actually, when people talk to me, they always say the Q guy or the review guy.
That dude, that weirdo.
Well, they don't say that, but they mean it. Morgan, how are you?
I'm doing pretty good. I am almost in the same place as Brooklyn in that I am about to be moving to Saskatoon, which is the other major city in Saskatchewan.
You are? Cool.
Yeah, so that's really exciting.
Is that in the planning? Because I don't remember you saying that.
Yeah, no, it was very abrupt.
It is? Okay. I thought so. Otherwise, you mentioned it before, but yeah, okay.
Yeah. But yeah, and musically, I just got my master's back for the album that'll be coming out on June 15th. So
cool. Yeah, we've got both exciting couple of months musically ahead. So
for sure.
Yeah, similar here. Dropping an album later in the summer, but the first single is gonna drop May 15th, and then another one hopefully June 15th. I gotta film a music video. Actually, Shelly-Ann our host that you all know from the other episodes, is my co-performer on the track, the one that's gonna drop first. Elana is my producer, also a co-host here. And Casper is the music producer, also a co-host here. So yeah, I usually reach out to my
Family
closest
affair.
network. Yeah. Also, I'm working on, and I can't say much about a big musical festival thingy happening in Pride, and that's all I can say right now. So yeah, there you go. Busy, busy people, and we got a beautiful guest with us who's got a big smile. So she's introduce yourself to us, Megan.
So my name's Megan Clark. I use she, her pronouns. I'm a family doctor in Regina, which, as we know, is Treaty 4 territory in the homeland of the Métis. I am a cis, white settler, able-bodied, straight. But thank you so much for having me. Morgan invited me here because to talk a bit about 2S LGBTQ plus or queer health. And because in Saskatchewan, I have the privilege of working with lots of folks from our trans and gender diverse community as my family medicine clients, and for gender affirming hormone therapy, surgical referrals, and even a few on puberty blockers. And I've also been involved with piloting a Peer Health Navigator project for folks who are trans and gender diverse. So Morgan has been involved with as well as part of our, we call it the T for T or Trans for Trans Knowledge Mobilization Council. So that is how I ended up here. And thank you for having me. You seem like a really exciting and welcoming bunch of people. So thanks for having me.
We try.
We drink lots of wine. We drink lots of wine.
Oh, don't give us
as Brooklyn takes us.
No, but actually, you know what? We always say at the show is we feel like it's a bunch of friends sitting around, although it's virtual, but a bunch of friends sitting around a table discussing a topic of the day. Honestly, I originally wanted to call it salon because that's the kind of feeling, the old salon. You kind of drop a topic and you're all sitting around the table having a drink or whatever and talking about something. So yeah, with that, the topic of the day, last episode, if you are following, last episode, we concentrated specifically to look at trans health and start that because it's a big component of our community's health, and that community struggles with finding the services. So we wanted to address that, but we're going to take a look at queer health in general and just kind of chat about what we think about that. And before we go to a break, that's the question that I think is going to lead the episode. I posted that I'm looking for anybody in my Peeps network is a queer health specialist or something in that area, and I got a bunch of recommendations. But one of our community members here asked, what's the difference? Is it the same normal health as queer health? Why are we different? Why are we separating ourselves? And I said, the thing is, of course, normal is a word just used, but we have needs different than the rest of any what do you call it? Any population, any community has specific needs for that community. So I thought I said trans, HIV, POC, people who may need more help, women health, etc. So that's the kind of, I guess, the basis in our discussion after the break is there a difference between that and that? All right, and we will be back right after the break, so don't go anywhere. And we are back with my lovely co-hosts and all those big smiles. I love it. We're discussing queer health today. And is there a difference between health and queer health? I looked up a couple of things. I don't know if it's going to drive the conversation. I looked up what is queer health on my phone before we started rolling. And I got this at the top. I guess that's an organization. Queer health advocates are trained volunteers who accompany and advocate for members of the community who are lesbian, gay, bisexual, pansexual, transgender, intersex, asexual, aromantic, queer, or questioning during medical appointments. So if there's a need for service to accompany you to a medical appointments, then I thought then there must be specific needs for medical appointments for certain members of our community. And then I asked specifically, what does queer health differ from mainstream health? And I got this.
In some respects too, I mean, it kind of starts with the feeling of safety, right? And knowing that the health practitioners themselves can either speak to what you may have going on, or what may be, you know, something that you're concerned with. And it could be from a sexuality standpoint, could just be from a gender standpoint. But that feeling of safety, I think, is really important. And I think that I'm sure, Megan, you probably experience sometimes that people think that just because you're a physician or, you know, medical doctor, that automatically everybody is going to be great and not have any biases or not. And you know that that's, you know, not necessarily true. Everybody has their own backgrounds and stuff, and you have an oath. But that feeling of being able to go into a space and it being welcoming and being okay, and you can ask anything and not have to. I mean, and I think about intersex sometimes too as a really specific kind of, you know, hard conversation to have and explain, and how it kind of impacts you. So yeah, sorry, that's I think that's kind of as
what a great point. What a great point. And I never thought, maybe I mean, I'm cis, I'm gay, I've got more privileges than others, but even that, now that you say that, if I walk into a doctor's office that I'm going to the first time, in my head I'm thinking, I hope they don't judge me. I hope that I don't feel uncomfortable talking to them or something. So there is still that. And I imagine that there's many other layers in our communities, other people that they have to think about. Megan, what do you can say on this?
Yeah, I think very, very consistent with what Kenney and you have said, Antoine. Like, I think there's a difference between culturally safe care and, unfortunately, right, the 2S LGBTQIA plus queer community struggles to obtain culturally safe primary health care sometimes. And I think we as the healthcare profession need to work harder at gaining those cultural safety skills. I know when I work with the trans and gender diverse community, I've had, oh, so sorry, I need to close my email because I have the Zoom link. I have arrived. I am here. I know when I've worked with the trans and gender diverse community, people have, a Regina community advocate and later said, you know, gender affirming healthcare really is culturally safe healthcare. So I try to use that terminology where there's gender affirming healthcare that could be healthcare that supports you in your gender. When you seek care for your broken arm or your toe infection or your abdominal pain that has nothing to do with your transition, versus transition related healthcare. And at my clinic, we work to offer both in a good way. But I agree. And my co-principal investigator for the trans project, her name is Dr. Stephanie Medill. She's a out lesbian physiotherapist who works with the School of Rehab Sciences at the University of Saskatchewan, has been involved with a research project that reviewed medical school curricula across Canada for like what learnings do medical students get with around queer health. And so she's worked with other people, including myself, to bring in more lectures and update the lectures that we do have at the University of Saskatchewan College of Medicine. And a big part of the work that the peer health navigators have done, and that I know a lot of community works in Saskatchewan and nationally and worldwide do, is working to educate healthcare providers on how to be better.
So that's happening. There's more. Okay. I got a couple of other things popping up on my screen with those searches. One of the advices how to improve LGBT health was display brochures and educational material about LGBTQ health concerns specifically in an office. But then right after that it says Canadian studies have shown that more than half of trans participants have had negative experiences within the healthcare system. 1/3 have not been helped, and long wait times have been observed. In addition, trans women are more likely than trans men to go without medical treatment. That's scary.
It's scary and it's absolutely true. Like I've had that. I got referred to a psychiatrist that was not gender affirming. And his first thing that he said to me was, "Oh, I see that you're trans. I'm not going to deal with that, but I can work on your mood disorder if you'd like." And I
Wow.
went,
Okay, I don't
Oh my gosh.
What the
Yeah.
fuck?
Yeah.
Seriously? Wow. Okay, that's actually terrifying.
And
Yeah.
That a professional and a doctor would even say that.
oh,
Kind
I
of
have
disgusting.
sadly heard worse,
Yeah.
even worse. Like that's bad. And I have heard even worse.
Oh
What
my
pairs with that too is intersectionality, because then if you think of from the indigenous community and two-spirit individuals, you have two-spirit, which is already something that people struggle with understanding. They assume it's something that it's not necessarily, and they don't necessarily know the background of and the history of two-spirit. And then you have indigenous issues as well that are in there, so it becomes even more layered there. And
Pile up your intersectionalities, yes.
And I
yeah,
think when we talk about healthcare in terms of 2S LGBTQ plus people, there's a conversation around barriers to access. So if you're living in a more rural community, it's that much more difficult to access someone who understands what your healthcare needs are, even outside of gender and gender presentation. Exactly what Megan said. If you come in with a broken arm, you're not going to want to deal with someone asking you about your vaginal health. You want to deal with your broken arm. So there's barriers of access, and there's also stigma as well. So something that I was thinking about, not to totally derail the conversation, but in advance of today's podcast episode, I was thinking about the Canadian blood ban and the fact that even today, you need to be 4 months clean from PrEP in order to donate. Or if you have multiple
Good point.
partners
Good thing.
and you're having anal sex, you have to abstain from anal sex for 3 months before donating, which I think, in a conversation of the umbrella of queerness, completely eliminates folks who are in polycules or who are operating from a non-monogamous standpoint but are still practicing safe sex.
Fair enough. Yeah. You said
100%.
something interesting actually about small town. Again, my mention about walking into a doctor and feeling safety. I would be terrified to walk to a small town doctor because yeah, the reality is probably they don't understand a lot of our issues as a community. Morgan, I saw you about to say something.
Yeah, for sure. I also wanted to say that even beyond the actual healthcare stuff, like if I bring a partner in that doesn't appear to be opposite gender of me when I'm going to get any sort of care, like, am I going to be dealing with, issues because of that? And is the doctor going to take me seriously and take my partner seriously? Like, as a polyamorous person, people assume that I'm a woman, even though I have a beautiful, luscious beard and am very obviously not, I think. But people will assume I'm a woman. And so if I were to bring my girlfriend into the doctor because I need
That's part of
support there and she was able to help me, and the doctor was like, "Oh, is this a friend of yours?" Like, no, it's a girlfriend. And then that immediately starts me on the wrong foot. And then getting to the healthcare stuff becomes less safe, less comfortable, less good, because I'm dealing with just the immediate gut reaction of somebody saying something stupid.
Oh my goodness. And it's so vulnerable to be in a closed room with a doctor. You're talking about a lot of sensitive topics that have to do with you and your body. And so you want to be in a space where you feel comfortable and safe with sharing that versus being guarded or defensive.
Fair.
Absolutely.
Anybody wants to jump on? Kenny. You're trying to say something, but
I am. I'm trying to formulate it in my head, and I guess maybe it's more of a question for Megan, being in the health services world, where I mean, brochures. I guess part of it is no matter how much you do, that's great on you personally, and even in your own clinic or whatnot, can be top notch and really doing a lot of things. How does the full when you look at the spectrum of healthcare in any kind of area, um, how do we get that conversation, I guess, happening a little bit so that there is more of a knowledge? Because I think that sometimes, and again, as Antoine has said, I am the real privilege that's on this screen in terms of
you're the top of the privilege.
a cis male, right? So my role and my job, and I think that we all have to do this, is to make sure that we don't necessarily lead into things with just our own image in mind. We have to think about everybody else's image and what they're experiencing in there. But how does that conversation begin? And to kind of change things up a bit, to show people that there's a change that needs to happen, and what they may not even realize is alienating about a practice or a space.
Okay.
Yeah, I think
not to give you a
it's huge. I think that conversation has started in some spaces and not in others. I think bringing in education from the beginning, the very beginning of medical school, like your first semester of medical school, is a great place to start to alert people to these issues. I also think that medical school training over time is working to become better. Just, frankly, to become more woke, to become more understanding of the social determinants of health and intersectionality and the many barriers and fog, like many layers of fog that we can have in front of our own eyes as clinicians and how those affect health outcomes. So I think that's one place. We're also bringing it into residency training, but the thing is it often relies on a local champion, right? Often somebody who themselves has lived experience, and so who ends up being, having that put on them as an additional thing that they have to do on top of their job or faculty position. Or sometimes it's somebody who's a clinical, somebody who works lots with the 2S LGBTQ plus community, especially the trans community, because there are some additional care pieces to transition related care where they end up doing the education off the side of their desk on top of trying to see all these patients. I think another way, and sometimes it can come forward through people having bad experiences and making human rights complaints, or writing to their ministers of health, or going to the health authority where they live, right? And learning from that process, from a bad event, from or a not, ideal adverse outcome. And I also think that for clinics who, there is somebody who's made a good relationship with a 2S LGBTQ plus patient, it can be almost overwhelming, because of course things travel through word of mouth because they have to, right? Like that's the strength in the community, and the strength of being in any community is people talk and say, well, I sought care here and it went well, but then the demand for that clinic becomes really big. So then that clinic on their clinic level, or potentially on their, health network level, it has to start the conversation about how to work in a good way, and for those providers at that clinic to address their own biases and how and just how they're going to build their system or build their capacity to work with people in a good way, I think. So those are places, and it still needs to happen.
Your clinic is for everybody, right?
That's right.
What specific topics do you see specific for our community, for the queer community that you find?
Yeah, well, first of all, there was a really good, what makes queer health different. And so I think, first of all, queer rights are human rights, trans rights are human rights. But I think as we've talked a lot about intersectionality, I think, first of all, people can struggle with a lack of cultural safety from their healthcare providers. So I think that's one issue, whether you're trans or otherwise queer, as we've talked lots about. Another thing I wanted to talk about was that there actually was an article about the case for a Canadian standard for 2S LGBTQIA plus medical education that was published in the Canadian Medical Association Journal in
Okay.
April of 2021. It's Googleable, like it should be open access, where they quoted a 2019 House of Commons report on the health of the House of Commons wording was LGBTQIA2 communities, finding LGBTQIA2 people in Canada to have, I just have it on the side of my screen here, worse health outcomes, disproportionate rates of cancer, chronic fatigue, heart disease, decreased likelihood of having a family doctor, and of course, the lack of access to primary care. I work at a residency program that trains family doctors is so vital for all Canadians. But of course, right, folks who are marginalized by society experience that worse, again, intersectionality and compounding, and increased likelihood to have chronic health conditions, poor mental health, and substance use disorders. And I think the reasons, right, that we talk about have to do with minority stress and marginalization and, right, a lack of cultural safety, both from the healthcare field and from society, and lack of access and fear around access. So I think that's where that's coming from. Yeah, the article says, and I quoted it directly, the historical and ongoing structural oppression of 2S LGBTQIA plus people has produced these health disparities.
Okay.
Yeah.
Thank you. Thank you.
And it's
Yeah.
it's not just the health disparities in the health side of things that we need to look at. It's also all of the precursors to health, having homes, having like you said, a primary care physician at all, having, good food to eat, having enough money to buy good food to eat, like all of those sorts of things. Because we're also underemployed, we're also underhoused, we're also like there's all sorts of social indicators of health that we have poorer outcomes for because we're queer and or trans.
Thank you. I was hoping that we can get to that point. The health is there, but how do you get to that? There's living before you have the need for health, and that affects our needs. Yes. Brooklyn is about to say something.
I think something that's so important in this conversation that Megan brought up really briefly in the open access document is substance abuse and addictions, because I find that that's endemic of people in the queer community not having access and self-medicating. So for example, I think of a lot of people who self-medicate using substances for something like ADHD, which is really hard to get a diagnosis for in women, or femme-presenting individuals, or autism, or even struggling with identity and not being in a safe place in your life using substances as a coping mechanism. And that's something that's like such a big issue, I find, in our community. I don't know.
It is.
Well, and chronic pain too.
Yes.
Right? Like there are a lot of queer and trans people with chronic pain, and it's very hard to get meds for people who aren't queer or trans. But then as soon as you add any sort of substance abuse stuff, they don't want to give you meds because they're like, oh, you're going to get addicted, and then you're going to be wanting it for your addiction, not for your pain. And it's like, if you're dependent on something so that you're not in pain, that is dependency, not addiction. Even if there is addiction involved, shouldn't people not be in pain?
Exactly.
Without judgment.
I guess I have a question that I would love to ask Megan specifically, is if, for example, I am a queer person, but I'm a queer person, I'm living in a really rural area, I don't trust the family doctors in my town. Or I'm living in an unsafe housing situation. Maybe I don't want my family to know about my situation. Maybe I'm under 18. What are some resources that I could use to be able to access healthcare for a variety of issues? It's a broad question.
Oh, great.
Yeah. I mean, first of all, I think I would say there are rural family docs and nurse practitioners who work really hard to provide person-centered, culturally safe care. So don't write someone off just because they're rural, but say you've tried to seek care where you are and you can't. I think one thing is there are, right, peer health navigator programs in almost every province that I'm aware of for trans people. Not always for otherwise queer people, but you write a 2S LGBTQ plus local organization might have something like Out Saskatoon's Q list, where they have a list of safe providers. Then another thing is with the onset of virtual care since the pandemic and the expansion of video care and phone care, that might actually make it easier for you to
Find
access.
yourself somebody you can do virtually. Yeah. Okay.
If you have, right, a phone that you can do a secure video chat from in a corner of your house where nobody can hear you or out in the yard, or you have a cell phone, right, with minutes, that those are ways that you could seek care, but that's something. But I agree that those supports are lacking.
Good
That
question. Yeah.
that pairs with kind of where my daytime work happens, is with not just queer, but just elders and seniors in general, especially when they're in the rural areas, because the virtual thing is possible if you have the capabilities. And as you get older, not everybody
Fair enough.
is savvy with things and that kind of thing. But as we age, and I think that it becomes a very, there's already depression and anxiety as you age because of isolation. And when you're in marginalized communities like this too, that adds to it even that much more. And I have this conversation all the time, and just from the dance world in general. So you can only imagine just how much it must be there from marginalization, where if you're fortunate enough to be in a community of marginalized people, like that there is an abundance of you, that's great because there's help there. But usually it's kind of sectioned off and there's not as much for you, so that kind of adds to it as well.
Have you ever experienced anything, Kenny, in healthcare that you felt because of who you are?
What I would say is that personally myself, no. And again, recognizing that I am cis white boy coming into a room who can change things up a little bit and talk the talk, walk the walk kind of thing. It makes things a little bit easier for me. But having my whole entire career up until just recently being in post-secondary, I worked with students for over 25 years. So when I go into a space, my first thing is to look at everything from the lens of not me, but from the lens of everyone else. Would they feel comfortable here? Because I would get the question, where would you send a student?
If everybody in the world does that, we would have a much better world.
well, yeah. And I think that, so, if it was, I don't think I think that maybe I've had a conversation once where it was kind of just talking about the fact that I had a same-sex partner, to which there may have been a stop in the conversation, but it didn't derail the conversation. But for the most part, when I go into rooms like that, whether it's, and I see this too, working in a clinic, in a wellness center, part-time, a lot of individuals very nervous about where they're going to go to, about who's going to put hands on them from a massage, chiropractor, physiotherapy standpoint, kinesiology, because of what they may be transitioning, or because of just the fact that there may be just such a nervous anxiety around who they are. I know a lot of young, queer men who are always I don't want people to think I'm coming on to them. And it's like, nobody should ever think that, but I get where your anxiety comes from. I understand. I can totally empathize with that. But yeah, for me, it's not really ever about me, because I've had the luxury of the world kind of giving that to this look, this face. It's always about thinking about what others may, because if you're going to suggest somebody go someplace, you should have gone through the checklist of how they would feel.
I would say I've never experienced particularly that, except when it comes to discussing sexual health. And I had times with doctors that I felt they're uncomfortable discussing me talking about, and I believe that our sexual health is a very, very important aspect of our humanity, and being sexual beings. So I felt uncomfortable because I can feel that they're uncomfortable talking about it. So that's the only times that I kind of. Brooklyn, anything that you can relay?
Oh my goodness. Morgan, did you want to say something? I feel like it's on the tip of your tongue.
I was just going to throw in there that the reason that they don't talk about it is because they don't talk about it with anyone. If we get people comfortable with queer health, they'll also be more comfortable with the sexual health of anybody, right? Like the cis hets are not okay.
Thank you.
I think for myself personally, I'm a walk-in clinic queen. I have not had a family doctor since I can ever remember.
Really? Oh, cool.
I'm quite a femme identifying individual, which means most of my walk-in visits are visits where I'm parading as my straight femme self. My spouse, she is more butch presenting, and she once had an experience with a general practitioner at a walk-in where they told her she did not need a PAP because she was gay. And the nurse was like, "You absolutely do. You should come back for a PAP." So that's one from this perspective. But also, just in this conversation, I think about the compounding of identities or intersections of identities. And I think that when we talk about the queering of health, it's important to recognize that a really large percentage of the disabled community, the deaf, hard of hearing, mad, blind, visually impaired community, and otherwise disabled community, really fall into a queerness umbrella, as well as fatness and accessing healthcare as a fat person, which is really important because the way you dress, the way you show up to the appointment often drives the conversation towards getting healthcare done. And I feel like, I mean, I can't speak for myself because I am no longer a fat person, but have felt that vibe of being in a doctor's office and being told that I could lose weight instead of addressing my actual health concerns.
Fair enough. Thank you. Megan, any? I'm trying to.
Megan's like, oh my God.
Yeah, I'm trying to form a question for Megan. You see people for physically, but then the layers of all this mental issues. What do you do when you're facing with that as a doctor?
Yeah, I think a good doctor digs in and talks to the person about the issue at hand, makes sure they're safe, tries to make them feel seen and heard as a whole person, and runs behind, right? Because you sometimes take the time. I'm constantly late, but that's because I try to take the time that each patient deserves. And when people
I'm gonna travel to Saskatchewan to see you. I like a doctor who takes time, not trying to rush you out of the office, kind of thing.
Yeah, and it's hard. And it's true. Like, I'm aware of all these issues in medicine, right? Like, there's education out there for doctors, right, about health at every size models and about focusing less on weight. Well, of course, we also are in the midst of still Ozempic's increasing popularity, right? And for everybody, it's their own body and their choice, right? And working with that person, but right, like, there is that. I do think sexual health is a very important part of health, and I normalize that. Yeah, I'm thinking a lot about how I try to normalize that for my cis het older guys with erectile dysfunction and my postmenopausal cis het ladies.
It should be something to talk about. It should be comfortable to talk about. Yeah.
Sexual health is an important part of health.
That's what I almost told one doctor. Is like, you know what? Stop disregarding my sexuality as an afterthought, because it's very important that you feel good, that you feel sexy, you feel sexual. Yeah,
and that you feel well enough to have sex, and that sex doesn't hurt.
Yeah.
And that sex is safe for you. Yeah.
You're also too, I guess, Megan, in your defense, in a way, you're catching a lot of baggage that all of us carry because for so many years we're told things or we're made to feel a certain way, and then we get to you and you're like, oh God, okay, so it's not just a broken arm. do you know what I mean? Like there's a lot that's there. And then again, that intersectionality kind of comes in and you add the queer layer on top of it. And you become a resource beyond probably what you thought was coming through the door, which has to put, and now I'm thinking about your health, has to put like a lot of pressure on you in terms of just that is a lot that comes to you.
Do you feel a lot of pressure?
Yeah, it is. I try to, right? And like we know that medicine is a profession prone to burnout, and doctors are right prone to mental health issues.
Humans.
Yeah, because they're humans, right? Just trying to support other humans. But I also always try to frame it as like, what a privilege and what a gift to be led into somebody's life and have them trust you and tell them and them tell you their story, right? What a privilege to be able to know people over time in the context of their personhood and their families and their communities. Is also a huge privilege. And so I think sometimes in healthcare, and I myself, we forget the gratitude because we're so tired, but it is a lot. And I mean, the lack of access to primary care compounds that as well, right? Because you tell your story to one person, or you want one person to be able to deal with and coordinate your whole health issues, again, in the context of getting to know you and your full personhood, in the context of your family and community, family, right? Biological, chosen, or otherwise, right? And community. And then like not everybody gets that because not everybody gets to access a family doctor. And of course, that's worse for queer people. That's worse for trans people, right? Also, back to the PAP thing, like you're talking about, you said your partner, she, her, but just it's a bit more masculine, a bit more butch, right? There is a common misconception that trans masculine people do not require PAPs. And right, when healthcare providers have biases, we put those blinders in front of our eyes and we silo people and we give people misinformation. But in 2021, I was part of a survey that was a resident research project with some other doctors who work in trans health and some other researchers. And we surveyed Sask family doctors, family medicine residents, and nurse practitioners on trans health. And we gave them a hypothetical case of a trans man with a cervix, and we said, does he need a pap smear? 6% said no, and 17% were unsure. So that's a quarter that wouldn't have offered this guy a pap smear who did need one. I think in the case he was actually far overdue for a pap smear. And of course, we don't want to coerce people into pap smears, and right, pelvic exams are sensitive and we need to be trauma informed as well. And right, we should never make pap smears or gynecologic exams a requirement for birth control or hormone therapy or otherwise, or STI testing or otherwise, because there's great ways for people to self-swab and pee in a cup for STIs that doesn't involve me looking at their genitals if they don't want me to, right? Genitals are bum if they don't want me to. Throat swab's a little hard to do on yourself, but people usually don't mind me doing that one. Although I always feel bad because people always gag, and I was like, I'm so sorry I'm doing this. I mean, I am happy to promote your sexual health, but pain to make their health better in the end. But right, I think that misconception, something else that happens a lot in healthcare is right, like queer health and trans health, as I've sort of alluded to, get siloed, right? Like, just like you said, happened to you with a psychiatrist, Morgan, instead of that psychiatrist offering to see you as a whole person. And also how maybe the issues you're facing and, around your transition and the personal development you're undergoing, and also maybe barriers to healthcare, or who knows, side effects of, I don't know what medications you're on, but side effects of medication could be affecting your mental health. And how transition is part of that, saying no. So like I never planned to be a gender specialist. I'm a family physician who does a bunch of different things in my practice, including full scope family medicine care. I don't deliver babies. About half the docs in my clinic do, but I chose not to do that. But like providing full scope family medicine care, I didn't plan to become a gender specialist, but I had a patient present to me when I was a resident who said, I'm here for a med renewal, turned out to be for her hormone therapy. So I navigated her transition with her. And I was the clueless healthcare provider who wanted to help this person and work with her, and thought it was such a gift to be following along during her transition with her. But I could have used the Peer Health Navigators back then because I didn't know how to get her the surgery she wanted. I didn't feel confident adjusting her hormones or its side effects, or their side effects, right? Not that she ever got any terrible side effects from hormone therapy, thankfully, because right, most people don't, because hormone therapy is safe, effective, and in fact life-saving. But
Clarifying that.
just as a healthcare provider, there's not a lot of support out there, and it's increasing. But that's eventually she brought a friend, and eventually I now have had the privilege of working with hundreds of people on their gender journeys, right? And then been part of the Pure Health Navigator project from a research perspective, because there was years ago, it's sort of dissolved now, but there was and other organizations and people have taken on the work. But there was a trans health coalition in Saskatchewan that was a group of trans and gender diverse people from 2S LGBTQ plus service organizations and healthcare providers who were like, hey, we have to do something, because clearly we had to do something. And that's what the Navigator project was born out of. And I, like I say, could have used them. But it does get siloed, right? Oh, you need to see Megan. She's a gender specialist. Well, actually, there's great guides, including one from Sherburne Health out of Rainbow Health, Ontario, for how every family doctor and nurse practitioner can prescribe hormone therapy. So that's something I'm proud to say that we teach at our residency program is.
Hey, Sherburne Health?
Yeah, Sherburne Health.
Yeah, that's the folks that I know that I was trying to get a hold of them and since the morning to try to get them on the show as well.
They would be better to talk to than me.
Oh no, don't say that.
They're fabulous. Yeah, I reference their guide on a daily basis, which
Really?
also is
Wow.
publicly accessible if anybody's curious. And there's the info sheets at the end about hormone therapy. But like, really, in my opinion, I think hormone therapy can live in primary care,
Okay.
except if people, have extenuating medical circumstances, right? But often can live in primary care. But again, it's like that siloing and that lack of access to primary care and that lack of access of medical student and healthcare provider education. And a lot of organizations and medical schools are working hard on that. But like those are the issues that sort of just compound and then.
Thank you. What you're doing is beautiful. And thank you for another awesome guest, Morgan, that you invited. But if we look at our guest from last episode and Megan, maybe there's hope for the future. Maybe we are getting better. Yeah, maybe we are getting better.
It's interesting that, sometimes again, when you're not in the thick of it and you're not impacted directly by it, you assume, we make assumptions. And I would assume that this type of care and everything that's happening, especially within the trans world, would have naturally become part of the education within the practice, right? You assume that, you're learning how to, take temperatures right up to somebody may have questions about transitioning. You think that in those, because I'm not a doctor and because I haven't gone through that, but you think that would be in there. And then you come to learn it's an ignorance on my part and on a lot of our parts where we
the last episode opened my eyes so much on the challenges of our trans community out there with healthcare. It was totally an eye opener.
Just calling it culturally safe healthcare changes the whole conversation. That just saying that and actually letting that sink in.
Thank you. We're going to start wrapping up just so we can stay on time. Anybody else has anything to add to the conversation, Morgan?
Can I do a little bit of a throwback to a previous conversation?
Sure.
We were talking about how sexual health in general needs to be more like people need to be more aware of it. One thing that we haven't spoken about is specifically health for ACE people and sexual health for ACE people, because often asexual and aromantic folks get told that they're broken and that they need to go see a psychiatrist. And then they'll go see a psychiatrist and maybe they get one that's good, or maybe they get one that goes, yeah, we need to work on this and get you having sex. And like, there's just, so I wanted to make sure we touch on the fact that there are people who don't.
You are in our community. You matter, and you matter in the conversation. Megan, anything to say on that?
Again, I think that is part of the education that needs to happen for healthcare providers. And I think, right, fundamentally, any healthcare provider, I don't know, should recognize that there is a wide diversity in what is normal. And that diversity makes humans, our society, richer and stronger and more beautiful. And and just to meet the person where they're at. Like, does it, right? Like, if they don't want to have sex or they're not romantically attracted to other people, does it bother them mostly just because it bothers society? Well, then maybe we should address that. It bothers society and reassure them that they are, normal and beautiful.
Thank you.
And that there
Like the
isn't
pressure
any
that we put
minimum
on
amount
women
of
to have
Yeah.
children, even if
I
a
know.
woman doesn't want to
There you
have
go.
a child,
Thank
there's nothing wrong with her. And it's that same kind of thing where it's like, this is what we've always known and this is what we think. So you should conform to that. You should want that.
Maybe stop. Maybe
Otherwise, there's something wrong.
Pathologizing, right?
Yeah.
That's the word, right? Like homosexuality was in the Diagnostic and Statistical Manual, as I'm sure you all know, of mental health disorders until I believe the late 60s or in the 70s,
yeah, I think that's it. Yeah.
right? And I think you're right. Like we pathologize based on bias.
Thank you. When we started the conversation, we said, is there a difference between queer health? I think we addressed it very nicely. I was also looking at a research from the University of Toronto, a team of lesbian, gay, bisexual, transgender, transsexual, two-spirit, and queer and ally researchers who focus on understanding how LGBTQ2S plus people experience physical and emotional mental health and how they access health services. If studies are being done about that, then it's safe to say that queer health has specific needs that are different from the mainstream health. And that's all what we can say. We can continue. I'm sure it'll pop up in other conversations in the future. We can revisit the topic. For now, we can take a little break and we will be right back. And we are back on the Queer Bunch, and we had quite a conversation, haven't we? And we were just saying in the break, maybe we'll come back, maybe we'll just revisit it again. There's so much to talk about in our community, and that's why we're here. If you think that you want us to talk about something specific, message us. Let us know. We can include that into our conversations. Before we say goodbye, we are saying goodbye. Why don't we propose this question, Morgan? Hond, my question to how do you take care of yourself, Kenney?
Oh God. I'm not very well sometimes. I will say. It's a learning process for me, and a lot of it is around time. It's making time for things and not saying I don't have time, but making time for things, and the things that I need to make time for is exercise. Air is a big one for me, and water elements. I like to be in water. I like to be near water. I like to be breathing actual air, good, clean, fresh air, being outside and just making time.
I love it. I love what you said, the time thing. That's my argument with my sister always. You have to make time for taking care of yourself, because you can't continue with all the other obligations that we have as human beings if you're not chopping a time to make sure that you're taken care of. For me, it's my bubble bath time. I read a lot about nutrients and food and what you put in your body. I like my couple of hours of winding down daily. That's the only way I can charge. Yeah, that would be my Brooklyn. You're on the road a lot. Do you have a lot of taking care of your time?
Oh, I am on the road a lot. I think that the way that I take care of myself is prioritizing my mental health, which I think is just as important as my physical
Very
health.
much so. Yeah. Morgan.
I think for me, it boils down to remembering that progress isn't linear, and like letting myself have bad days, but not letting the bad days ruin the progress.
Well, I love that. Cool. You are so wise. We love it. Megan, let's see how a doctor takes care of themselves.
Well, I'm so lucky to have a support network, a friends, family, and a very cute gray tabby, my
Ah,
only child.
no.
Her name is Bear. She's the love of my life.
Oh, sweet.
Um, and I think it's the regular things. I have an ironic hobby for a doctor. I'll tell you one of my secrets, which is that I like to bake.
That's
Ironic
meditative.
hobby for a doctor. But
Meditative.
hey, we all need to bake for wellness sometimes.
I
Or many people need to bake for wellness sometimes. It's all about balance and moderation.
love it. Cool. Thank you. Thank you for being on the show with us. We really appreciate. I speak for myself only, but I appreciate all the wisdom and everything the light that you shed on the conversation. Any last words, beautifuls?
Last words are, if we're going to have health for anybody, we should have health for everybody, and that includes people in Palestine.
Aw, thank you. Health for all. That's the way. That's the way to go. Kenny, last words.
Just I enjoy these types of conversations. I don't think they happen regularly enough. I think that we are bombarded on the daily with so much stuff that to take time out and to have a conversation like this, even though it's for a program, actually gets you in touch with some things that maybe you miss at times because they've come up in these conversations. So I really appreciate them.
Thank you. Well, I'm glad I
Thank you,
invited
Megan.
you to be part of this. And Brooklyn, last words.
I don't have any. I'm just excited to be a part of this conversation, and I hope it keeps happening.
Thank you. Thank you. Megan,
I just want to say thank you so much for having me. It's been such a thoughtful and lovely and wise conversation, and I could talk for hours and hours more with you folks. We didn't even talk about PrEP or gender affirming
oh
surgical.
God, don't start again. Okay, let's
Exactly. We
extend
can't
that.
start again, but I had such a great time, and this is such a huge topic, but I really, really enjoyed our conversation.
Well, we don't.
Thank you
Maybe
for
maybe
having
we'll get you back on. We do. We are going. I'm pretty sure throughout. We just started. This is our third episode as a group. Third or fourth? April 4th. Uh, yeah. So, but I'm sure I'm sure we're gonna like. There's definitely PrEP. That's a big conversation on its own. There's a lot. Yeah, we're gonna probably look at HIV issues along the way and all that sort of stuff. So yeah, we'll see where we can get you back in again. Hopefully in the future. And until then, all our lovely viewers, take good care of yourself. Stay healthy.